I'll go ahead and get started by introducing myself briefly and then Rishi. So my name is Shiv Gaglani. I'm the co-founder and CEO of Osmosis. This is actually the 10th Ask Me Anything we've done over the past 18 months, featuring Rishi talking about COVID and all the updates that have been happening. And so Rishi, if you go to the next slide, let me introduce you. So many of you already know who Rishi is. He's our Chief Medical Officer at Osmosis, and he's a pediatric infectious disease attending who, before joining Osmosis, was the head of medicine and health at Khan Academy, where he built out their MCAT and NCLEX content. And before that, it was in the Epidemic Intelligence Service at the CDC in Atlanta, where he led a lot of viral outbreak research. So we joke that all of his experience has been preparing him for this moment, both for discussing virus outbreaks and vaccines, as well as educating students and the public about these very complex and often confusing topics. And we know how important the right information is these days, because if we're seeing it actually play out here in the US, where misinformation, people not understanding the guidance or not following the guidance, is leading to this resurgence in Delta, which is why we decided to do this Ask Me Anything again. So thank you, Rishi, for joining and for leading this. And we'll go ahead and get started with handing it off to you to take us through the AMA.
Awesome. Thank you so much. One thing I'll just say right off the bat, a lot of the people in the audience are probably vaccinated at this point. And as you know, there are many people in this country, in the US, that are unvaccinated. I happen to live with one of these people. We discuss it every day. I'm joking, of course, but it's my 4-year-old son. And so those that have kids, obviously, will probably have questions at the end. And so I'll try to go through this relatively quickly. And at the end, we can talk about vaccines, COVID testing, travel, and all the other things that may be on your minds. So here's the status of where we are today. I grabbed this a couple of hours ago. The very unfortunate #1 ranking for the US still in terms of number of cases, number of total deaths. So this just helps to ground where we are with COVID. In the US, top 10 states, California has the #1 rank there as well, although Florida and some other states are making a real run at that right now, with cases surging at the moment from Delta variant. This is an overall view of kind of where things are shaped up over the years. So year and a half now. So we've got, obviously a number of cases right now. This is the second largest peak that we've had. The winter still is the largest peak. You can see some kind of maybe minimum signs for hope. The cases seem to be kind of plateauing a little bit, at least week to week. You see the kind of general peaks are just a little bit lower or a little bit higher, but not nearly as high as it was the jump week to week prior to that. So hopefully that will start to plateau off. And then in the next 2 or 3 weeks, hopefully we'll start seeing that decline that we all hope for. So a quick recap of the disease itself, and this is important just to keep in mind as we talk about kind of long haul symptoms, but COVID-19 is a virus. It is going to infect primarily 2 types of cells, the cells lining the lungs and the sinuses, the upper airways, as well as infecting the endothelial cells. And so a lot of times, people wonder, just natural curiosity, like how do you get neurologic symptoms? How do you get cardiac symptoms, strokes from COVID-19? How is that even happening? And that's because it's the virus infecting the cells lining the blood vessels. And of course, the blood vessels serve every major organ in your body. And so that's why it can cause disease in every major organ in the body. Now, one thing that we've come to realize is that it's not just acute symptoms. A lot of people will get acute symptoms. The minority of those people will go on to get hospitalized, and the minority of those people will die. But the majority of symptoms are happening among patients that are not getting hospitalized. But the key thing is that not getting hospitalized doesn't mean that you're in the free and clear. A number of countries have now reported data, China, Germany, UK. These are just a handful, as you might imagine, basically reporting that people are having prolonged symptoms. And this has been termed long hauler. And this can range from cough, shortness of breath lasting months. Over 50% in China had decreased PFTs, pulmonary function testing, a month after discharge. Germany, they saw a few months afterwards, they saw some cardiac issues, specifically myocardial inflammation, which is inflammation of the wall of the heart. So the entire wall of the heart was inflamed months after the diagnosis. And then you're seeing shortness of breath. And these are oftentimes follow-up studies are 1 or 2 months. Sometimes these symptoms can last much, much longer. And then there are neurologic symptoms. And this is something that we've come to kind of recognize about COVID, is that it uniquely seems to affect the nervous system, specifically things like sensory loss, taste, smell. But also you see, and this is actually interesting, mobility challenges. And I bring that one up because if COVID-19 is affecting a lot of the elderly, and if among the elderly, you're having mobility challenges, maybe difficulty walking, being stable on your feet, then that hip fracture that someone suffers could be attributed back to COVID-19 because they fell maybe at home, maybe a few months after they had COVID, and that wouldn't get caught. So there's a lot of secondary sort of negative externalities that are occurring because of COVID-19 that aren't always caught in the data. But if you listen to the stories, it's very clear that that would likely tie back to a COVID-19 symptom that went on and on and on. Now, it's obviously terrible when people suffer from COVID-19. The other issue that all of us are now very, very acutely aware of is that viruses mutate. And so the way to think about an infected individual is that they essentially become, willing or not, a virus factory, that person gets infected, the virus mutates inside of them, and you get new strains. And the reason that we sometimes call it a mutated virus versus a new strain is just really the degree of mutation. So when enough mutations accumulate and you start seeing changes in function, at that point you start calling it a new strain. And so these are subjective differences. These are not objective, criteria laid down. But teams of scientists kind of define new strains, and essentially, therefore, every time you have more and more disease, even if it's mild, right? Even if you have lots of mild disease, maybe you're not getting the hospitalizations and deaths, people might say, well, why worry? The worry is that you are allowing for these virus factories and these new strains come out, and you see how quickly these strains are causing more disease. And so it could be that maybe it's mild today, but severe tomorrow. So this is a website that I love to follow. It's called NextStrain. And it really shows you pictorially and with color all the new strains that are emerging and over what time period. So look at the x-axis on the bottom. You see, 2020 September here, 2020 December. And you can see that this is when Delta came out. So Delta came out in that time. And it wasn't on people's radar until earlier this year. And so you can see how it emerged and sort of was in the population for a little while until it really started exploding and additional mutations were accumulated. And at that point, it was able to really take off. So I bring this up just to show you that these are constantly coming out. Like there's, you can already see a theta on this list. There will be a kappa there, right here on this list right below delta. There will be an omega. There will be new kind of strains that are going to constantly come out. And it's our challenge to identify them quickly, track them over time, and see which ones we need to worry about and test against. So this is kind of real-time data. It can be a little overwhelming, but it just goes back to that previous slide of accumulation of strains or mutations creating new strains. And what that means is that every part of the world is kind of facing a slightly different challenge, right? Like compare what Australia is seeing to what you see in South America. Just by the colors, you can tell that these are different viruses that they're dealing with, and that means that the clinical data that they're referring to in terms of like what are the best treatment modalities, do you use drug A or do you use drug B? It's going to differ. Australia is going to have to have different guidelines versus let's say Peru in this case. So this is what everyone's dealing with, and of course it changes not just over geography but over time as well. So of course the vaccines are there. Here we are, a year after roughly when these vaccines started kind of becoming ones that we started speaking about, thinking about, and getting ready for. And these vaccines were all made against wild type. They were all made against kind of that first strain that was initially identified in China. And they're all targeting this very conserved region, meaning a region that we don't expect to change too much, but it can change a little. and that little is what we're basically fighting with right now. And so this conserved region is on this protein, the spike protein. The spike protein is kind of the key that allows the virus entry into the cells. Remember, we talked about the two types of cells, the epithelial cells and the endothelial cells, sort of the blood vessel lining cells. So it's getting into these cells with this spike protein, and the virus is therefore kind of beholden to the spike protein. Can't change it too much, otherwise you can't get into the cells. And so as a result, it's a great target for the vaccines. And all the vaccines, all the major ones target this spike protein. And so the CDC is, of course, following strains very closely. They've identified strains of concern. I highlighted 3 of them here on the left: alpha, beta, and gamma. And then the big one, Delta. And it was first identified in India. But notice that all of them were identified in other countries. Alpha was first identified in the UK, beta in South Africa, gamma was in Japan and Brazil, and this one is in India. And so what you're quickly realizing is that regardless of what happens in the US, we are going to have to watch what happens in the world, because that's where these variants are coming from, and essentially now coming back to the US with travel and folks coming into the country. It's gonna spread here as well. So we really are going to need to vaccinate the world if we want to eventually see this go and get into kind of a steady state where we're living with COVID, but in a way that doesn't cause the hospitalizations and deaths. So they have it broken down into kind of 4 categories: spread, severe illness, vaccine, and treatments. And these are the 4 questions we should be asking ourselves every single time there's a new variant. I know, like I said, there's going to be new variants on the rise constantly. And each time you need to be thinking of these 4 questions. So I broke it down on the next slide. Is it more contagious? That should be the first question we ask. And with Delta specifically, yes, it is much more contagious. To put a number on it, its R naught is around 3.5. The R naught of the wild type, the previous strain we're kind of dealing with, was around 2.5. So 3.5 people get this virus from an infected person, whereas with the wild type, it was about 2. So obviously many, many more cases that are going to arise from this. And this is the major issue, because again, if it's more contagious, that allows for more virus factories, and that sets you up for the next variant. So you can see kind of the cycle that we're in right now. Next question, is it more virulent? And here the data is much more ambiguous. It seems, and this is after reading a bunch of different literature over the past few weeks, it seems that it is slightly more virulent, and it is primarily in the elderly that we're seeing that. Again, that's of course where most of the disease burden is at. As yet, it's not clear if it's more virulent among kids. It's not clear if it's more virulent among young adults, but it does seem clear that it is more virulent among the elderly, and the data is going to come in the next month or so as we get more cases as to whether it's actually more virulent among adults. I'm going to jump down to the question 4 now. Do treatments work? Because this is tied to virulence, right? We think of virulence in the sense of hospitalizations and deaths. And if you keep in mind that some treatments are being used before someone gets hospitalized, then of course that's going to be tied to whether we think something is more virulent. And it seems that right now, steroids and remdesivir, which are the mainstays of therapy, are very effective against Delta. But in red, I wrote, but monoclonal antibodies may be less effective. And so that's tied to why we think it may be more virulent. So again, it could be that the strain is simply not responding to the therapies as effectively, and therefore we're calling it more virulent, right? So it goes hand in hand. And that's very unfortunate, because monoclonal antibodies have been a major part of treatment for patients before they get too sick. And so if you can't use them, or if they're not as effective here, then that sets you up for trouble, and you end up getting more hospitalizations, and hopefully people get better, but sometimes people end up getting hospitalized and then dying. And then finally, vaccines. And this is, of course, the ultimate issue. Are the vaccines protective against severe disease? Yes, you may still get a little sick, but does it prevent hospitalizations and deaths? And the answer is yes. They do seem to be very protective. The 3 major ones, J&J, Moderna, Pfizer here in the US, do seem to be protective against severe disease. But, and this is a huge exception, but vaccinated people can still spread the virus, and at rates that are similar to unvaccinated individuals. So in other words, if you have 2 people that are both going to get COVID, and one had the vaccine and one didn't, both individuals can shed the virus at a similar amount in their nose. And that's a big, big issue, because if they're shedding it at a similar amount in their nose and their mouth, they can spread it out there in the world. And that is a big reason why masking was remandated by the CDC when they evaluated that data and said, okay, it seems that even vaccinated individuals can spread Delta, and because Delta is surging, we really need to get everyone on board with wearing masks again. And of course, the question marks for the next variant. We don't know what the next variant will hold for us, but these are, again, the 4 key questions we should be thinking about. So I wanted to bring this up again because I want to show you when these things emerged. So the big arrows are kind of to point out that a lot of the things that we're talking about, the variants of concern, 4 of them, alpha, beta, delta, gamma, are ones that actually came out last year. So, prior to 2021, we already had these circulating, in fact, well before. And so sometimes they're circulating for a while before they really take off. And there is this 5th one, lambda. It's not considered a vaccine of concern. It's considered a a variant of concern. It's considered a variant of interest. And that's because it's still unclear whether lambda is circulating at a higher rate, whether it's causing more disease here in the US. And it's a variant of interest because in some regions it is causing more disease. And so this is a blow up of that map I showed you earlier, just showing you Peru, Ecuador, and Colombia. And here you can see the lambda variant is really taking over, especially in Peru. And they had issues with Delta as well, but you can see lambda is really dominating over Delta there. And so the concern is, if that's happening in Peru, Ecuador, and Colombia, could that also happen here as well? So that's why it's a variant of interest and is being closely followed. And again, we're trying to answer those questions for lambda just as we were for delta. Is it going to be treated with our current medications? Is it going to cause a disease among vaccinated individuals, or are they protected? Those are the 2 kind of big ones. And then, is it more virulent and is it more contagious? So there's this question of herd immunity. When are we going to be done with all this? When will we, as a herd, as an American herd, be protected? And of course, we are getting more and more vaccines into people's arms every day. But there are issues about defining herd immunity. And I just put a few here for you to consider. We have multiple vaccines now with different efficacy rates. It's unclear how long immunity is maintained. How long does someone with Pfizer go before they need another booster? And how does that compare to someone that had Moderna or J&J? And which kind of person needs a booster? Is it someone that is 90 years old or someone that is 50 years old? Is the immunity going to last longer among the 50-year-old versus the 90-year-old? And qualitatively, the answer is yes. Yes, we know that the immunity lasts longer in younger, healthier people, but how much longer? And all these factors get into who is susceptible in a population, because that is part of how you define herd immunity. So that's why the R naught value, and the R naught value is, of course, changing over time, as I just mentioned, because each of these different variants has a different R naught value. And of course, every geographic population has a different spread of these different variants. So altogether, the whole point I'm trying to kind of make here is that all the variables that get into herd immunity are shifting over time, right? As the exact virus mix shifts, the herd immunity kind of needed to defend against it is going to shift. And of course, it's not a static population. You got people flying back and forth. Many people are starting to fly again for business and for personal reasons. And so all that said, or driving even, all that said, as you move from one community to another, the percent of the population vaccinated may differ. And so as people shift and as time moves, the herd immunity calculation starts to get a little fuzzy. So the numbers you hear, 70%, 80%, 90%, that really is not fixed, because it depends on exactly what variant you're talking about at a given time. This is where we are with vaccine manufacturing. So we also, on the flip side of the equation, we're trying to get more vaccine out. And I wanted to show you just visually how complicated that is, because if you're talking about biotech here in the bottom middle, their footprint is very different than the footprint of, let's say, Oxford, AstraZeneca, or even Pfizer. So each manufacturer has different capacity, and of course, they have contracts with each of these countries. All said, it's very hard to simply raise production and expect that to immediately get into people's arms. The story for all, it's not even 9, it's actually 16 of these, the story is going to shift, right? So each one has a different story in terms of where they stand with getting more and more vaccine out. And so the big challenge right now is getting more vaccine into people's arms. And this is where we are globally with vaccination, because we know the variants are coming from abroad. So it's great for the US to be protected, and that's important. But if new variants are coming up where vaccines are not going to really give us full protection, then what you ultimately care about is how is the world doing? And globally, and this is from August 10th, globally, you can say Europe and North America are doing relatively well. South America is right there, but Asia, Oceania, and Africa are doing much, much worse. And of course, because Asia is where the bulk of the population lies, that drags down the average. And so you can see the average here for the world is we're sitting at about 16% fully vaccinated as of now. And so there's a long way to go, even if I don't tell you the herd immunity figure, but you know it's going to be somewhere in the range of probably 70, 80, 90%, somewhere in that range. There's a long, long way to go before we get there. And so this vaccine production issue is increasingly what we all need to focus on, and getting the vaccine out to the areas needed most. And of course, it's not equally distributed. It's much easier to get vaccine into, let's say, a higher income country with a large urban center where you can kind of logistically do that much more easily than it is to get vaccine into a low income country where the population is distributed in rural areas, and it's really hard to get it out there. So getting vaccine into low income countries will be a challenge. And of course, that's where the lowest vaccine rates continue to be. But every individual has the capacity to become a virus factory. And even those individuals that are in those low-income countries, if they create, if there are opportunities to create mutants, those mutants can easily get out and can spread. So new updates. This is brand new from the FDA. They authorized a booster dose for certain immunocompromised individuals. I just highlighted a sentence here. They said people who are immunocompromised in a manner similar to those who have undergone solid organ transplantation. So essentially, very, very immunocompromised. Anyone that's gone through a bone marrow transplant would qualify, but those are the kinds of patients we're talking about. So we're not talking about patients with, let's say an extended course of steroids because they have asthma. That would not qualify. So these are pretty severe immunocompromised individuals. There are likely to be other groups that will be included. I'm referring to maybe the elderly. You could easily imagine the elderly with severe cardiopulmonary disease might be part of this as well. So really groups that are at high risk for getting the disease and having a bad outcome, as well as those that probably didn't have a great immune response to the first dose or 2 doses of vaccine and likely need a booster for that reason as well, because functionally they are like unvaccinated individuals. So this is hot off the press. There's also a letter that went out from the AAP, and the letter was from August 5th. And this basically said the Academy, the American Academy of Pediatrics, believes that clinical trials in these children being those under 12, can be safely conducted with a 2-month follow-up for participants. And this is because currently the expectation is that it's going to require a 6-month follow-up. A 6-month follow-up would take us into spring of next year. And so the AAP and others are advocating for getting the vaccine after a 2-month review to kids, because the thinking is that we've seen this in adults. We're seeing more and more cases of kids getting hospitalized. We've had deaths among kids, that the benefit here outweighs the risk, and that 2-month follow-up should be more than sufficient to see if there's any sort of bad or untoward effect. So if that goes through, we would expect to see kids getting vaccinated November, December of this year for kids over 5 and maybe under 5 soon after. So that is the hope of the AAP. So we'll see if that bears out. Here's where we are in the US. This is 50% are fully vaccinated at the moment, about 59% if you talk about partial vaccination. This is using the denominator of the full population. Of course, as you just heard me say, many people are not eligible. So, if you take kids out of the equation, then of course the percentage rises. And this is where we are with hospitalization rates by age. I just want to show you this because I think sometimes data can be shown and can make people kind of misinterpret or maybe draw inappropriate conclusions. So this is on the left, how we are doing with cases. This is hospitalizations, new admissions among kids 0 to 17, you can see where we are now versus where we are at the peak previously. So this is clearly much higher, right? And that is, I think, a testament to the fact that Delta is spreading faster. And so if it's going to spread faster, you're going to see more cases. And what's not clear is whether this hospitalization rate also reflects more severe disease, right? So is it that it's more severe, or is it that it's just a bigger group of kids that are being infected, and therefore, of course, you'd see more cases getting hospitalized out of that? That is not clear. And so that is something we have to kind of tease out. Essentially, are these kids sicker than the ones that were coming in before, or are they baseline the same sickness, just more of them? And then this on the right shows all age groups, and you can kind of see where we are if you stratify by age. That it goes in age order. So the darkest line is the oldest group, and kind of younger and younger and younger. And I just wanted to show you this kind of gold line at the bottom that looks like it's not moving at all. This is the left graph kind of blown up. So even though sometimes on a scale like this, it seems like, oh, kids are kind of getting sick at the same rate, it's because those rates were always quite small, but now we're seeing those tiny, tiny rates get a little bit bigger. And so this is how I would look at the data right now. And you can see across the board, more and more people coming in and getting hospitalized. This is how COVID compares with flu. So this is just, this is from the Lancet. If you look at the red, and the blue line is COVID, the red line is flu, and this bottom x-axis applies to both graphs. So you can see older age groups here on the right, younger on the left. And so in terms of proportion of patients who get into the ICU, maybe a little bit worse with COVID here among the folks that are over 60. But then the real difference is that once you get to the ICU, the number that die is quite high with COVID, right? That's the big difference. So similar numbers kind of hitting the ICU, but many of these folks in the red will survive, whereas many of the folks in the blue will not. And so that's the big difference that we're seeing on that side. And then here among kids on the right here, you can see, again, with flu, number that end up going to the hospital, pretty low. Number that go to the hospital if you're sick with COVID as a child, 4, 5, 6 times higher. And similar with, this is mortality, sorry, and this is the ICU on the top. So on the ICU, a few times higher, but again, same story as before. You're seeing the same increase in mortality risk among kids. So this is what I think a lot of people use sometimes when they're trying to compare COVID to something that they know. And this should show that clearly many more people are getting sick and dying, as well as many more people are getting COVID in the first place versus flu. Now, I was sent this video in anticipation of the AMA. Someone sent this to me and said, hey, can you just comment on these videos that are circulating out there? This is from Mount Vernon, a school board meeting where the doctor gets up and basically has certain points that he makes about COVID-19 and his beliefs about how it should be managed. I watched the video, it was 7 minutes long. You can see it was kind of viewed 1.4 million times. And he makes a few points, and I just wanted to kind of show you how dangerous some of the thinking is. I mean, he's a smart sounding physician. He's an MD. And he says things like, well, masks filter down to 0.3 microns and the virus is smaller. And so masks don't work. Now, when you hear that argument, that sounds logical. If the mask has a certain hole size and if the virus is smaller, then of course it wouldn't work. But what he doesn't mention is that viruses rarely are floating in the air on their own. They're usually part of a droplet. And those droplets are usually larger than 0.3 microns. And that's why masks work. Moreover, even when viruses are kind of free floating, they are part of what's called Brownian motion. They shake quite a lot. And when they shake and move around a lot, they get caught up in the fibers. So it's not like they can kind of really skillfully get through a net, if you're imagining a net, and get through the other side. They shake so much that they get caught up in the fibers, even when they're not part of droplets. He talks about antibody-mediated enhancement, which is a phenomenon that has been circulating on the internet quite a bit. Antibody-mediated enhancement is something that we see with other viruses like dengue, but has not been seen with coronaviruses in the past, and certainly hasn't been seen with SARS-CoV-2 at all. And so that's another interesting thought. It's a good scientific question. It sounds scary when you hear it and you don't know what it means. But with COVID, we have not seen that. And the concern there is he's saying, well, when you get the vaccine, it creates antibodies, but antibodies can actually make diseases worse. And that is true of dengue. But in certain cases, of dengue and not broadly applied to everything. And in case of vaccines, you can see that we have many vaccines that do work. So clearly on the face of it, that logic doesn't hold. He says, well, with smallpox, you couldn't eradicate smallpox, or you could eradicate smallpox, but you can't eradicate this. So what is the point of trying? And again, with smallpox, there was no animal reservoir as there is with COVID. And again, the idea is not to get rid of COVID off the face of the planet. What we want to do is basically recognize that COVID is here to stay. It exists in bats and other animals as well as humans. It's not going to go away, but we got to figure out how to coexist with it, and the way to coexist without causing hospitalizations and deaths, and probably will be much more akin to what we do with flu, where flu is not being eradicated, but we are at a place where now with flu vaccine and other things, you can mitigate the amount of death and disease from flu. So similar idea with COVID. So all of this is to say that, these arguments are out there, and there is an information war happening. And on our side, we've been doing our best to kind of fight that war, fight the good fight. We've been putting content out. We've been partnering actually with YouTube to put content on vaccine hesitancy and many other video topics out. We recently started partnering with Facebook to get content out there as well around myths and facts in little bite-sized bits that people can understand and follow. On Instagram, we've been doing these wonderful Raise the Line interviews with phenomenal key kind of opinion leaders. This is Shiv talking to Ashish Jha from Brown. And so we're doing our best to create opportunities to get these myths dispelled, to be able to answer questions that people raise in a thoughtful and in a logical way, and ultimately to help us get through this. We say at the end of each of our Raise the Lines, we're all in this together, and it's not just lip service, we really mean it. So I'll pause there with questions. These are the references, and I'll send this around so folks can kind of download this stuff if they're interested, and happy to take any questions.
Thank you, Rishi. We have a couple of questions that came in through the chat, starting with Tamara. Tamara, you have two questions. Maybe if you don't mind, you can unmute and ask them directly, and feel free to introduce yourself if you're willing.
Hi, Rishi, and hi, everyone. Yes, so my questions are basically about the kids that cannot get vaccinated yet. I'm from Peru, so my time for my kids to get vaccinated will be much longer than yours. And we keep seeing, and you showed the graphs of kids getting into the ICU, hospitalized, even dying. But what are the characteristics of those kids? That is information we are not getting. So my kids are healthy, they don't have asthma, they don't have anything. Would they be at risk for this? Or what is happening with those kids that are getting hospitalized?
So I'll start by saying the vast majority of kids that get COVID do not get hospitalized, the vast majority. Most kids that get COVID are going to have symptoms that do not land them in the hospital at all. That said, they are looking at whether kids that don't get hospitalized still get long hauler symptoms, and whether those long hauler symptoms last for longer. And there is some early evidence that might suggest that. So for example, you might get a cough that doesn't last for 2 months, but maybe 4 or 5 months, as an example. And so again, with Delta, it's hard to say because Delta hasn't been in the population. It's been in the population, but not at this level. And you just told me you're from Peru. So of course I'm thinking less Delta, more Lambda. And so we don't know how long Lambda causes long haul symptoms. What we do know is that it seems like it goes longer. And again, that's not just cardiopulmonary, but also the neurologic symptoms as well. So loss of smell, loss of taste, things like that. But in terms of who gets sick, like if you had to build out some characteristics, you're right. It's usually kids that are going to have some level of disability in their lungs that are going to be at higher risk. Of course, we've all heard the story of a totally healthy 5-year-old that gets hospitalized, ICU, and dies. We know that story. But generally speaking, that's not the case. Generally speaking, healthier kids that don't have any sort of asthma or pulmonary symptoms don't tend to get as sick as those that have sort of underlying chronic illness.
Okay.
Sorry. One other thing I just want to mention, there is a phenomenon called Misc. I didn't talk about it, but this idea of kind of inflammation that you get that happens like a month, 6 weeks after the illness. So that's another thing to look out for in kids that do get COVID. If any of you parents have a kid that has COVID or might get COVID, 6 weeks, 8 weeks afterwards, these kids sometimes get rashes, inflamed eyes, inflamed mouth, strawberry tongue, and that can cause disease of the heart blood vessel, the blood vessel serving the heart. And so that's something to look out for. And we've seen that with both wild type as well as Delta.
Okay, and the second question she was mentioning was, here in Peru, it's been circulating that if you have the vaccine and you get COVID, you are more prone to make more variants of the virus. So I kind of know the answer, but I wanted to confirm with you.
Yeah, it's a good question. So let's say there are two people, one vaccinated, one unvaccinated. You still shed the virus, which means that you're at risk for creating a mutant, a variant. That's true. And it is high among vaccinated, which was kind of surprising. Like people thought it would be a little bit lower shedding than you would expect. But you shed less than if you were unvaccinated. So you're not putting the country, your community at higher risk by getting the vaccine. It is still lower risk. But not zero. You're still shedding it, and you're still able to make mutants and variants.
Thank you so much.
Great questions. Next, we have a question from Vern Rambo. Vern, do you want to unmute and ask that? And then after that, Bill Chapdelaine, feel free to ask Bill. Thanks for joining.
Sure. Thank you. And thank you, Rishi. I appreciate your time always for these presentations you give. My question has to do with, it seems all we hear is vaccinate and wear a mask. Are there any other health items we can do to prevent or reduce the virus? Or any common traits among those that are severely, in ICUs or even dying? Is there anything else we can do? Even hand washing, it seems to have kind of gone away from the message. So any other advice to us?
Well, one other thing I'll just say, which there's a lot of data around this, and so I feel very comfortable saying it, is vitamin D. And so making sure your vitamin D levels are normal. If they're not, you should get supplementation. It has been shown through many studies, even prior to COVID, we knew this with respiratory diseases, that those with low vitamin D levels are at higher risk of getting ill and also getting severely ill. So I would recommend, if your D level is low, now is a good time as ever to go out and take a walk in the sun, or alternatively just grab some supplements and take vitamin D. So that's one small thing that isn't as talked about, like you said, as the others, but I would say has a lot of literature support for it.
So Rishi, it's Bill Chapdelaine and Shiv. I just want to take you up on that offer. I think I'm going to go take the afternoon off and go walk in the sun. Thank you. No, I want to thank both of you for these, this and the previous sessions. They're tremendously informative, and I think folks really appreciate it. So thank you both very much for doing this. My question was around some of the immune suppressing medications that people take. And I was wondering if the CDC guidance, I think they've been talking about it, but I don't know if they've released anything around people who take like TNF inhibitors or things like that. Have they said anything about a booster shot for people who are taking those kinds of medications? By the way, Jessica had asked a similar question. She mentions RA specifically and that those kinds of medications.
Yeah, good question. So for those that may not know, rheumatoid arthritis is RA, and those that have autoimmune conditions in a family of conditions often take TNF inhibitors and things like that, tumor necrosis factor inhibitors. So those medications in my mind are kind of a class below what they've currently released. So when you have a solid organ transplant or BMT bone marrow transplant, you're taking kind of a class of immunomodulators or inhibitors are more severe inactivity than the TNF blockers that you're kind of alluding to. Could it extend to that group? I think there's a very good possibility that it could, especially as we get more data on like what are antibody levels among the people that have had those diseases, because there are many of those folks. So we can follow them over some time and say, wow, they're actually still protected. We're good. Or no, it seems like they're drifting down. We need to give them a booster. But that is not something that I've seen come across. And I think that probably won't be the next group. I think the next group will most likely be the elderly. And then maybe a group after that. Now, of course, there's a bit of an ethical dilemma, right? So if we have, let's say, 100,000 vaccines sitting around, do we ask them to go out and become part of the booster sequence for these folks? Or do we donate them to, let's say, a country in Africa where the vaccine rate is quite low, and we're concerned that they're going to send a variant back here? And so that's the issue that we'll have to kind of think through as we expand out the circle of folks that get the booster.
Thank you, Rishi.
Awesome. Thank you, Bill. The next question is from Angela. Angela, do you want to unmute and ask that?
Sure. I was just wondering, what can I say to people who are hesitant to get the vaccine because they worry that there's not enough data yet about potential long-term effects? I have a family member who's even a nurse who got it only because she had to, but is kind of helping to spread misinformation. Well, I hope it's misinformation about arthritis being an effect, premature births being an effect, just all kinds of things like that.
It's a good question. So I would say one thing that I think can be useful is just people that are often against the vaccine are often thinking of it as like this foreign substance that's in their body, right? Like that's kind of at a visceral level, like that's what people think of it as. And that foreign substance is this mRNA stuff, right? This mRNA kind of gets in your body and like, you have to do something with it. I would remind them that that mRNA, it gets in your body, and mRNA doesn't linger, doesn't stay around for months. You know, it's going to go away on the order of hours to days, you know, after it's kind of absorbed in. And the virus, like the alternative, is that you get the virus. And what do you think the virus has? Well, it has all that stuff and more, right? It has the ability to create spike protein, the same one that the vaccine is trying to get you to make. It's going to come in and linger not for hours to days, but days to weeks to months. So if you're really against that foreign substance, you'd want it out of your system as quick as possible, right? And so why would you reject something that's going to be around for hours to days and then accept something that's going to be around for days to weeks to months? That's one line of reasoning that could be useful. Another is to say, like, let's count the number of people that have died from the vaccine, like worldwide. How many is that? The number is 0. Like, we haven't had deaths from the vaccine. How many people have died from the wild type disease? So no matter what sort of outcome you're interested in, like, it's precipitously lower. Like, even if it's something like arthritis, even if that were true, how many cases of arthritis have we seen among COVID-19? Hundreds of thousands of people have had arthritis, you know, with all the long haulers. So all those concerns to me kind of wash away. And then finally, with worrying about outcomes, I would say, well, it's not like our first vaccine that humanity has created. We've done this many, many times, right? 20 plus other vaccines. How long does it take typically to kind of see an outcome that is concerning? 2 months, 3 months? Like that's why the AAP said 2 months, right? Because usually you see that in the first 2-month window. You don't need 10, 12 months to see the outcomes. You get those within a couple of months. And so we know this based on the many other vaccines that are out there. So what is the holdup here 10, 12, 14 months after vaccine? It's kind of strange.
I agree. When I brought up other vaccines that people have no problem with using, the argument was, well, those are established and have been around for, you know, years and years.
Yeah, and that's a fair point. They have been around for longer. That's true. I guess what it comes down to is the now, you know, millions of people that have gotten this vaccine. And so the outcomes that we would see in all those other vaccines, we saw them oftentimes in the order of tens of thousands of people, didn't take millions. And we've already crossed that threshold. So you don't need 50 million to see an outcome with the 20 plus other vaccines. We saw it within tens of thousands. And now we're 2 orders of magnitude above that, 3 orders.
Okay, thank you. That's great.
Rishi, I also know some people had emailed you questions in case you want to read one or two of those out first, and then we'll go to you next, Tamara, again, and others can feel free to type just their name out, raise their hand using the emoji function. We'll call on you. We have about 11 minutes left.
Awesome. Yeah, one of the questions that came in via email, I touched on, but we can go a little deeper, which is around misinformation and how to dispel it. And so I think one of the challenges, and this one actually for whatever reason came up a lot, and I feel like they kind of cycle through, but this antibody dependent enhancement, it's this concept, and I feel like this happens a lot where scientists will use a buzzword, and I include myself in this. Like, antibody dependent enhancement is not, ADE is not something that people talked about 2 months ago. I mean, even today, a lot of people are like, what is that? And then if you hear a person saying this, and they sound sort of competent, you believe it. There's this sort of halo effect of like, well, he sounds smart, so then what he's saying must be right. And those two things are not always true. And so I would just caution, folks that believe because the person sounds smart. And the best retort is to send it to someone else, and I would invite you to send it to me. If you'd like me to respond to something, please send it to me, or please send it to someone else that might be able to retort some of these smart sounding arguments. Because on their face, they sound reasonable, but if you dig, they're not reasonable. And so that's I think the big challenge that we're seeing is that the misinformation is now kind of stepping up a bit and getting a little bit more savvy, and our response has to be equally savvy.
And Tamar's asking a great question about people who've already had the vaccine, already been infected. So natural immunity versus vaccinated immunity, and which one's more effective. And I know, Rishi, having worked at the CDC, you're familiar with the report that came out 2 days ago about that kind of dispelled the fact. I think it was 2.34 times more effective getting vaccinated in terms of reducing symptoms or infection. But maybe you can comment on natural versus vaccine. So how do you talk to somebody who's already gotten the disease and convince them to get vaccinated, especially if they think they're immune?
Yeah, so the virus is kind of a sneaky bugger in the sense that like it has, as part of its arsenal, it has a way of sort of hiding away from your memory cells. So your memory cells are out there trying to do their job, trying to remember, just like we all try to remember names at a conference or whatever, like they're trying to do their best to remember the virus so that next time they're ready. The virus hides from those memory cells really effectively. So if you allow the virus into your body, what's it going to do? It's going to hide from your memory cells. But if you don't invite the virus in and instead just kind of invite a protein in, well, that protein doesn't know how to hide from your immune system. And so you get the full memory. And that full memory translates to a longer period of time where you're covered and protected. So a lot of folks will say, well, you know what? I had the natural infection, therefore my body's going to take care of it. And your body is great at taking care of viruses and bacteria. I mean, certainly thousands of years we survived as a species, and we had to interact with different viruses and bacteria. I will also remind you that it's a war, and sometimes not all species do survive. And so viruses and bacteria have put some species out of business because they've won the war. And so you don't want to go that way. You don't want to say, well, we will always survive. There's no rule like that. And so as a result, you want to try to enhance and stack the deck in your favor and get the longest memory you can. And what happens naturally is that the virus has this little trick up its sleeve. You're kind of not letting it use its trick, and therefore you get more protection.
Great. The next question is from Christian. Christian, you want to unmute and ask?
Yeah, sure. It's just more about the authorization of the vaccines. I keep hearing that it's only been granted emergency use authorization, and when's the real authorization going to take place? Because until that happens, it's not really an approved vaccine.
It's a good question. And this is my number one frustration with the FDA, is that the country wants to hear the word approved. And they don't care about the mumbo jumbo about processes and like how it's always been done and how long it takes, et cetera, et cetera, et cetera. They just want that word. And EUA, emergency use authorization, is not the same as approved. And those processes are different. And I would have hoped that given the magnitude of this crisis, that the FDA would have recognized that difference and said, you know what? Normally we have these two kind of parallel tracks. We are going to use the word approved for this virus, and we're going to put whatever manpower or womanpower we need to get that done. And so that we can get rid of that argument of like, it's not been approved. Just for y'all to know, that approval is based on post-licensure, post kind of phase 3 trial data. So they want to see in the real world, how does this behave? And typically they want to watch it for a number of years. That's great. In times of peace, that makes perfect sense. That's how you want to do it. In times of war, I think that process is probably not the one to follow. And I think that they should have kind of gone the way of approval so that people don't worry about like, it's not FDA approved.
And Samir, did that address most of your question, or do you want to unmute and ask any follow-ups?
Yeah, no, I didn't see that Christian had asked that seconds before me. So yeah, that helped. Thank you.
Awesome.
One thing I'll say is that typically after the data is submitted, it takes about a month for the FDA to kind of go through that data. That's another delay that I wish that they didn't have. They have these kind of meeting cycles. I wish it was the next day, that they just like spent all night in a room, essentially just pouring through the data and making sure that they feel comfortable with it, and not have even a day of delay.
The next question is from Joyce. Go ahead, Joyce.
Oh, sorry, I can't remember where I read this, but just in the last couple of days, I read that the Pfizer vaccine might be less effective against the Delta variant. So I wondered about your thoughts on that.
Yeah, I read that too. And you know, at first blush, that can make people think, oh, then, you know, thank God I got Pfizer. I'm sorry, thank God I got Moderna instead of Pfizer, or what have you. I would just remind us that, you know, we're in this for a long haul. And tomorrow we're going to wake up and talk about, you know, Kappa or, you know, Omega or the next one. And each of these viruses is going to react differently to the vaccine. And maybe on this one, Pfizer did a little bit, let's say, worse than Moderna. Maybe for the next one, it's going to do a little bit better. That's one variable. The other variable is time. You know, if you recall, Pfizer had sort of a 95% VE and Moderna had a 94% VE at the outset. You know, I don't know if you all remember that initial data point. And people were like, oh, so Pfizer's like 1% better. So wouldn't I just get Pfizer over Moderna? But then what really matters is kind of how that looks by age. Like, is that the VE that you would get as, let's say, for myself, you know, I'm a man and I'm 40 years old. Like, is that the same VE I would get versus someone else that's maybe a woman in her 80s? So the VE is going to differ by age and gender and ultimately by you. And then differ over time. It's going to change over time. So I'd rather have a VE that's maybe a little bit lower but lasts a long time versus one that's like a smidge higher but then falls precipitously. So all those kinds of things should be taken into account when you're thinking of the ultimate issue of better, because all those variables account for what is better protection.
Thank you.
Great. We have 3 minutes left, so probably can squeeze in 1 or 2 more questions. Feel free to unmute and just ask it directly if you have one.
So if if there's no more questions, I'm from Peru, and I'm a physician. So I got the Cinefarm vaccine. Do you have any, I don't know, something to tell me about the efficacy of that? I'm going to travel to the US in November or December. I hope to get my kids vaccinated there. Or I hope I can do that. But should I get another vaccine then? I got vaccinated in March.
Yeah, it's a good question. So the quick answer is I don't know about Cinefarm's data. The 3 that I've reviewed extensively are the 3 here in the US, like J&J, Moderna, and Pfizer. But the broader question is a very common one that's coming up more and more of like, what if I had J&J? Should I go and get a second mRNA vaccine or something like that? And in your case, like you had Cinefarm, and should you get it? Maybe another vaccine? It is being done. Like that's the bottom line. People are doing it here in San Francisco. The Department of Public Health has allowed people to do that. And so if it's being done, it's going to be studied. And so over time, we're going to get some data back on like, do you see a boost? Does the vaccine kind of become a blended average? Like what happens to those people? When you get 2 very different types of immunogenic responses, do they cancel each other out in some way? You know, so we don't know, but there will be papers coming out about it pretty soon in terms of whether it seems to be beneficial or not.
Great. Well, safe travels tomorrow when you come out to the US. I know we're at time, so to be respectful of your time, we're going to wrap up here. I really want to thank everyone for taking the time, and of course, Rishi for always being a voice of reason and education. And if you have any other questions, you can email rishi@osmosis.org. And we'll probably have to, you know, the more AMAs we do, the worse the situation is, it seems. So hopefully you will not have another AMA, but if you do, you know, we'll be here to help, and feel free to just be in touch with questions, with other ideas for things we could be doing to help combat misinformation, or just help you with what you're trying to do personally and for your organizations. So thanks again, and have a good rest of your day.